Special guest in the studio this morning is Dr. Robert Vlach. He is a urologist with the Wisconsin Institute of Urology in the Encircle Health building here in Appleton. Good morning, Dr. Vlach. Welcome.
Good morning, Kathy. Thank you for having me in the studio today.
Nice to have you here today. We're going to talk about prostate cancer, PSA testing. But before we do that, tell me what a urologist is.
A urologist is a surgical subspecialist who deals with conditions of the male and female genital and urinary systems. Mm-hmm. So we deal with kidney stones and urinary incontinence, various sorts of cancers, kidney cancer, prostate cancer, bladder cancer, testicular cancer.
Do you have to go to take special classes to be a urologist over a medical doctor?
Right. Well, of course, you go to medical school, mm-hmm. and then you enter a urology residency, which is either 5 or 6 years. Okay. And the first year or two you spend in general surgery and some of the other surgical subspecialists, and then the final 3 or 4 years you spend just in urology, mm-hmm. learning, urologic surgery techniques mm-hmm. and conditions.
What made you decide to be a urologist?
Well, that's an interesting question. Well, in urology, we usually help people. Mm-hmm. So if someone can't urinate, then you can help them urinate. That they usually like that. Mm-hmm. And we have a wide variety of surgical procedures and breath that we see in the office and in surgery that make it challenging but fulfilling.
Mm-hmm. All right. 281-1150 is the phone number if you have questions for Dr. Vlach today. Also, you can use our toll-free line, which is 1-866-887-1150. I want to get right into the prostate issues. Tell me what a PSA test is.
Well, PSA stands for prostate-specific antigen. It's a protein that's produced by the prostate gland and is secreted into the prostatic fluid, mm-hmm. Which makes up most of the ejaculate. When there's a problem with the prostate, there's a backflow of the PSA protein into the bloodstream, and you get an elevation of the level. Mm-hmm. So that's how we measure the PSA blood test.
So what's the normal level? What is the normal level, and when is the level high enough to be of concern?
Really, when PSA first came out 30 years ago, we felt that the normal range was 0 to 4. Mm-hmm. In the last 15 years, there's been a shift to altering the PSA ranges based on age, because as men get older, the prostate gets larger mm-hmm. because of benign growth of the prostate. And that leads to a slight rise in the normal levels of the PSA. So we adjust the PSA for the age.
Mm-hmm. Is the prostate cancer screening harmful?
Well, it depends. All things have complications right. involved with them. So you have to weigh the benefit of screening versus the potential negative impact of any side effects with the tests to detect it or the treatments. Mm-hmm. So I would say that, we have to weigh it to see whether it really is harmful in the certain situation with the individual patient.
Well, let me ask you this. Who is most at risk for prostate cancer?
Well, certainly men with a family history of prostate mm-hmm. cancer have a higher risk. And so all men with a risk of family history of prostate cancer should start screening for prostate cancer at the age of 40.
At 40?
Yeah. Mm-hmm. Also, Afro-American men are at higher risk for prostate cancer, and so they would fall in that same early screening range. Mm-hmm. If one does not have a family history of prostate cancer, then the American Urologic Association recommends screening every other year with a PSA and a rectal examination. You have to do both tests every other year from 55 to 69. Mm-hmm. After that, into the early 70s, it really depends on the patient's health and a direct discussion with the doctor about mm-hmm. the relative benefits and risks of screening.
Mm-hmm. Okay. 281-1150, if you have questions. Ladies, you can call in, too, if you've got husbands that have problems. Now, not all prostate problems are cancerous. Is that correct?
Correct. Actually, the majority of prostate problems are due to benign growth of the prostate, which is very common in men after the age of 40 or 50. Mm-hmm. There's a slow, gradual enlargement of the prostate, then that leads to some of the symptoms that men often have with their urination, weakening of the stream, getting up at night to go, more frequent urination. We can also see prostate infections and urinary tract infections from an infected prostate. So.
Okay. So what kind of symptoms are men experiencing if they have prostate cancer?
Well, in the early stages of prostate cancer, they often have no symptoms, and that's why it's hard to detect just based on symptoms. Now, some men will have prostate cancer in conjunction with enlargement of the prostate, so they may get the fairly typical urinating symptoms.
Okay.
In the advanced stages, however, prostate cancer often spreads to the bones, so they could get bone pain in the spine or the pelvis. They may develop pain in the side from obstruction of a kidney. Those would be the major signs of advanced cancer.
Okay. But there's this, so the screening doesn't necessarily detect prostate cancer?
The screening is helpful.
It's helpful.
Yes. So the PSA blood test and the rectal examination together have been found in a number of studies to reduce the mortality rate from prostate cancer. There are three major studies that have looked at that. One did not show that finding, and there were significant problems with that study. And then there were a couple from Europe that did suggest there was a 30% reduction in mortality from prostate cancer with early detection.
Is there any other type of testing that you do besides the PSA and the rectal?
Sure. If one has an abnormal rectal exam or a PSA blood test, you can't say they have prostate cancer just because of that.
Right.
Those tests are not specific or sensitive enough. So if we're suspicious for it, the test that we do is an ultrasound of the prostate. We do that in the office. It's about like having a 5-minute rectal exam, and then we take little needle biopsies of the prostate. And send those to the pathologist, and he examines the tissue under the microscope.
Okay. 281-1150, let's go to the phone lines this morning. Good morning, you're on the Good Neighbor Show with Dr. Vlach.
Hello, Kathy.
Good morning.
Hey, Dr. Vlach.
Hi.
I was a patient of yours when you were on Grant Street.
Okay.
And I had 2 procedures with a lithotripsy, which didn't work very well for me. And then you told me to take aspirin, and my problems went away.
Wow.
I just wanted to thank you very much. I'm still breathing.
Oh, great. That's good to hear.
Thank you.
All right, thanks for calling. 281-1150 is the phone number. If you have questions today, give us a call. Going to take a quick break. Be back with more of the Good Neighbor Show in just a moment. You're listening to the Good Neighbor Show on 1150 WHBY. Dr. Robert Vlach is my guest this morning. He is a urologist with the Wisconsin Institute of Urology in the Encircle Health Building on Capitol Drive. And let's go to the phone lines. Good morning. You're on the Good Neighbor Show.
Good morning, Kathy.
Hi, good morning.
I have a question for the doctor.
Sure, go ahead.
Okay, doctor, a little background. I'm a male, age 70, generally good health. Get my prostate checked, yearly. As a matter of fact, I just had it checked about 3 days ago. The initial problem is frequent urination at night. I'm on a Flomax, I believe it's called, or Tamsulosin right now. Been on that for several years. That seems to work. But the big question is, I'm up quite frequently during the night to urinate, whereas during the day, everything is normal. I was just wondering what and my prostate, by the way, this last check from my doctor said it's quite normal, didn't feel any growths on it, and he said that we could rule that out as a problem.
Right.
So,
there's getting up at night to urinate is sometimes a very frustrating problem because sometimes it's an effect of an enlarged prostate, and that doesn't sound like it's the case for you. But as the prostate enlarges, it blocks the flow of urine off from the bladder, and the bladder responds by getting overactive. And it seems a lot of that overactivity manifests itself at night where you have to get up to go. But if the prostate's not enlarged, there are a couple of other conditions with the bladder that can cause the getting up at night. And one would be just an overactive bladder, so the bladder muscle itself is irritable and it doesn't like to expand and stay expanded until it tells your brain that it wants to evacuate. And there are medications that can help with that, although generally I think that those medications don't lead to great results with getting up at night to urinate. And then there are a lot of men who, and older people in general, who mobilize most of their body fluid at night when they're recumbent laying down as opposed to during the day. The heart doesn't pump as well as it used to, and so the fluid accumulates in the lower extremities during the day, and then your body, when you lay down, it's easier for the heart to pump the fluid through the kidneys, and then you produce urine at night. And that's that can be a frustrating problem. It's not really a prostate or a bladder problem. It's just a matter of producing more urine at night.
I see. I am, as a side note, I am on a mild dosage of prednisone for rheumatoid arthritis. And I already talked to my doctor. It's only 5 milligrams a day. He said that should have no bearing on the urination. Is that right?
Yeah, it shouldn't unless you're having some fluid retention issues from the steroid effect.
Yeah, no, that doesn't seem to be a problem. Well, okay, doctor. Thank you very much.
Mm-hmm. Thanks for calling.
Appreciate it. Bye-bye.
Sure. Bye-bye. 281-1150, good morning. You're on the air with Dr. Vlach.
Hey, good morning, Dr. Vlach.
Good morning.
I am 69, and in the last 8 months, I had 3 occasions where I've had urinary infection and it's been treated with an antibiotic. The lab work on the tail end of my last event indicated that I had a slight infection yet, and I should come back in another month to check that again in the lab. And, of course, just want to make sure that the antibiotic is going to do the trick. It's called a SMZ-DMP DS 800-1600.
Yep, that's Bactrim would be the brand name, but that's trimethoprim sulfa, fairly standard antibiotic for urinary infection.
Mm-hmm. And so what brings on the infection?
Well, in a lot of older men, because the prostate is enlarged and the bladder is being affected from that, sometimes the bladder is just like when you're lifting a weight and you repeatedly lift the weight, your muscle becomes fatigued. Well, the bladder muscle can do the same thing, and as that starts to happen, you start to retain urine in the bladder. And just like with a stagnant pond, it gets kind of mucky and yucky in the summer with the hot weather. Your bladder can be at risk for forming bladder infections with that retention of urine. So older men who have urinary infections should be evaluated for that problem and prostate enlargement.
Okay. Thank you.
Sure.
All right, thanks for calling. 281-1150, good morning. You're on the Good Neighbor Show.
Hi there. Good morning. I am calling with a totally unrelated question, but I have a hard time getting a hold of you, Kathy, to do this. Can you give me the email address for Chef Jeff? I was wanting to get his oatmeal recipe.
I think off the top of my head, it is Chef Jeff at fvtc.edu. I think that's what it is.
Okay, I will try that.
All
Thank
right.
you so much.
Sure, you're welcome.
And also thank you for your program because you do offer a lot of good help for a lot of people.
Oh, thanks for calling. Appreciate it.
Thank you. Bye-bye.
Bye-bye. 281-1150 is the phone number. We're talking with Dr. Robert Vlach. He is a urologist with the Wisconsin Institute of Urology. And if you're having any problems whatsoever, whether it's your bladder, your prostate, give us a call. No question is out of order. If you need help, it's important that you get the right answer, the right diagnosis. Prostate cancer, how prevalent is it in men?
Well, prostate cancer in 2014 was and has been the most commonly diagnosed cancer in men. Last year, about 230,000 men in the United States were diagnosed with prostate cancer. Of that number, the number of men that died of prostate cancer last year was 30,000. Mm-hmm. So a significant number of men do die of prostate cancer. Partly that's related to the number that are diagnosed with it and get it. The chance of dying from prostate cancer in the first 5 years of diagnosis, however, is very low. Mm-hmm. So when we look at treatments and patients' overall health and their candidacy for treatment of prostate cancer, we have to look at their overall health condition to see if they would benefit from potential treatment, because it takes 10 or 15 years to see that benefit. And that's been pretty clear in the screening studies, that you don't start seeing benefit with screening until that, 7 to 10 year time frame down the road. So in a man who is 75 years old and he's got a number of health problems, statistically, he's not going to live long enough to see the benefits from treatment of prostate cancer, whereas a 50-year-old man certainly would.
So what are the treatments? What kind of treatments are available?
Well, the standard treatments for prostate cancer, at least localized prostate cancer, because you have to look if it's localized to the prostate gland versus metastatic, because the treatments are completely different. But for localized prostate cancer, the standard treatments have always been surgery to remove the prostate, and most of the time that's done now laparoscopically using the Da Vinci robot. There's radiation therapy, and there's a couple of different types of radiation. There's the standard external beam radiation therapy, and then the other type of radiation would be where they do the radiation seed implant, so brachytherapy. And then the final treatment would be cryosurgery, which is a freezing treatment of the prostate. So those are the standard treatments for cure for localized prostate cancer. Also, with the more we learn about prostate cancer, there's been a much more focus recently, I would say in the last 5 years, of something called active surveillance, meaning that even though you diagnose prostate cancer, it doesn't mean that you always treat it, and you have to individualize the treatment. There are some men who, statistically, based on their biopsies, their PSA levels, their clinical stage, have a low risk of progression in the short run, and they may elect to just watch it till a time in the future when we show that it's progressing.
Yeah, that was one of my questions. How fast does prostate cancer spread?
Usually it spreads. It is slow growing, and so it takes a number of years to spread. But that all depends on where you find it on the time continuum of when you're diagnosing it versus the time it would spread. So with screening, you shift that point that you find it farther to the left on the line, so that you have a much longer period of time before it might metastasize. What we really hate to see happen is a man that may or may not have thought he was having screening for prostate cancer in the course of his routine physical exams, and then he presents with a very high PSA and metastatic cancer, and he has no chance of cure. And that is a tragic situation, because we can typically avoid that situation with screening for prostate cancer.
So when a man goes in for his annual physical, should he ask for a prostate screening?
Well, I think that that is a controversial topic these days. I think as urologists, we think it's important for men to talk to their doctor about the option for screening for prostate cancer, and based on the potential, their age and their health, decide whether it's right for them. And but I mean, we feel in healthy men over a 10-year life expectancy between the ages of 55 and 69, they should have a PSA every other year. Okay.
All right. Let's go back to the phone lines. Good morning. You're on the Good Neighbor Show with Dr. Vlach.
Oh, yes. My name is Mark.
Hi, Mark.
I've had my prostate, my PSA has gone up pretty high right now. How soon could I get in to see you?
Well, what we would have you do is call our office, and we would see when the next appointment is. Typically, it's not too long out into the future. It's within a couple of weeks, certainly.
I've got an additional weakness. I've had Parkinson's for 23 years.
Okay. Yes, Parkinson's disease can, and some of the other neurologic conditions can affect your bladder, and you can get symptoms that one may think are from the prostate enlargement that are actually from the effects of the Parkinson's disease on the bladder.
Oh, well, thank you very much.
Sure.
You're welcome. And do you want to give a phone
number? Sure. Our office number is 739-3537 here in Appleton.
Okay, and I will repeat that number throughout the show, 739-3537. All right. Let's go back to the phone lines. Good morning. You're on the Good Neighbor Show with Dr. Vlach.
Good morning.
Morning.
I'm a 61-year-old man, and this might sound odd to you, but I try to avoid going to doctors.
We hear that a lot.
The urine flow is slow, and it's the worst early in the morning. Like if I urinate 5 minutes later, I need to go again. There was a thing on TV about some additive or supplement that you could take, and it would shrink the size of the prostate. And I'm thinking, well, and I didn't listen to the whole program, but there was something about painful and something about bleeding in there, and I tried to avoid both.
Mm-hmm.
So I went to the pharmacist, and he said there's really nothing over the counter that would help to shrink the prostate. Is that your opinion, too?
Right. You see a lot of commercials on TV, certainly. I know I like to watch the History Channel, and I see that all the time, super beta prostate and whatnot.
Yeah.
The thing about medicines for urination is that if you give a man a sugar pill and you tell him it's for the prostate, 30% of them are going to get better. That's called the placebo effect. So there's a large placebo effect in any medical therapy for...
I can eat more sugar if you think that'll help.
No. But the prescription medications for prostate symptoms really have been well studied in what we call double-blinded randomized studies, which take care and account for that placebo effect. None of those herbal substances have gone through the rigors of a good medical study like that to prove that they're worthwhile. So I don't really tell patients that I have a strong opinion that they should take it. I know that there are lots of people making lots of money on those supplements, and that's why they're advertising.
Right, and that was kind of what the pharmacist was explaining to me, and I just thought I'd short of going to the doctor and doing the testing and prescription, that's it.
Right. No, I think you would be someone that we would say would probably benefit from a visit to check it out.
Okay.
All right. Thank you for calling. You're welcome.
Bye-bye.
Bye-bye. 281-1150. Good morning. You're on the air with Dr. Vlach. Hi, good morning. Hello? Are you there? No, I guess not. All right. We need to check in with CBS Health Watch. Be back with more of The Good Neighbor Show in a moment. You're listening to The Good Neighbor Show from the OSI studios of WHBY, and my guest this morning is Dr. Robert Vlach. He is with the Institute of Urology here in Appleton. If you have a question, 281-1150 is the phone number. One of the questions I want to ask you, Dr. Vlach, is when should you see a urologist?
Well, when it pertains to the prostate, of course, when one has symptoms, or if one is, been found to have an elevated PSA or an abnormal prostate exam. But some of the other things that we do would be kidney stones. So if someone has pain in the side or blood in the urine, or recurrent infections, those are people that we see. Oftentimes we get called from the emergency room in the hospital with patients with kidney stones. So. We also see patients who have urinary leakage problems. It's a very common problem in men and especially women. Yeah, and so we deal with that whole gamut.
Do you ever deal with children and bedwetting problems? Is that something a urologist would handle?
Yeah, I think our role as urologists really is to give reassurance in that situation, because it's very, very unlikely that there is a anatomical or serious kidney or bladder problem present in that situation. Most of the time, bedwetting in kids, and we see a lot of kids with it, most of the time it's related to just a delay in the normal maturation of how the brain takes over the functioning of the bladder from an infantile bladder. So, but it can be very frustrating for parents, and there are some treatments, but it's a lot of time it's a waiting game.
Okay, so don't get too concerned if your child is wetting the bed.
Usually not.
Let them mature a little bit.
Right. If they're starting to have bladder infections or problems with incontinence during the day or bowel incontinence, then that would be signs that it might be more serious.
Okay. 281-1150. You can also use our toll-free line, which is 1-866-887-1150 if you have questions this morning for Dr. Vlach. And let's go to the phone lines. Good morning. You're on the Good Neighbor Show. Thanks for holding.
Hi. I have a question in regard to female urinary incontinence. Are you familiar with the interstim therapy.
Yes.
Do you see much of that or much success with that in your practice?
Well, urinary incontinence in women can be kind of classified into two broad categories. One would be what we call urge incontinence, which is due to an overactive bladder, a bladder that doesn't relax like it should and stay relaxed until it's full.
And that's my case.
Okay. The other type is stress urinary incontinence, which means that you leak when you're physically active due to laxity of the muscles.
And that I don't do.
Right. So for your problem, really it's kind of a continuum of treatment. And the first line of treatment, after we're sure there's no infection, because infection can cause those types of symptoms, and that you're emptying your bladder out completely, the first line of treatment are behavioral sorts of modifications, and if those don't work, then there's a lot of medicines that are available to try to relax the bladder. And those probably haven't been successful in you.
Yeah, I haven't. I'm on the Vesicare. I have been on it for a couple of years, and it definitely helps. If even I forget one day, which doesn't happen very often,
right.
I know it, but it's still it's really it's an issue.
Sure. So,
and I did go for that interstim the
test.
The test, yes. And that did not do a thing for me. It didn't help me really at all.
Sure. So if the medicines aren't working for that condition, then there's three other types of ways we can deal with it. The first would be this interstim that you're talking about, which is actually a nerve stimulator that's implanted under the skin in the buttocks, and there's little wire leads that are going to the nerves coming out of the spinal cord that affect the bladder. And with stimulation of those nerves, about 50% of people with urge incontinence will get better, okay?
Right.
And it varies between people. And so you've had the test stimulation where they just put the leads in from outside the body and stimulate to see if it helps.
Correct.
Other treatments for that are nerve stimulation of one of the nerves in the leg called the posterior tibial nerve. Okay. And that's a course of treatments that's done in the office, which is less invasive because there's no nerve stimulator that has to be placed surgically, which it can benefit. And that's fairly new, and some of the insurances in Medicare have now started to cover it, which is always one of the things that keeps it from being broadly available. And then the other thing that is quite helpful these days and is actually FDA approved now would be Botox injections into the bladder. You've heard of Botox injections many other places. Yeah, but we are also now injecting that into the bladder. It often has to be repeated, but it does oftentimes lead to a dramatic improvement.
And once you do that Botox, because that's the next thing I'm looking at, that just lasts for a certain amount of time, just like an injection would anywhere else, and then are you talking about more than once a year to have that redone? Yeah. It's
real variable. The effects can be seen for up to 6 to 9 months.
Oh, okay.
So I mean, because it takes a while for the body to degrade that Botox and for the effects to go away. So, but it is something that if it works, it often does have to be repeated at various intervals.
Okay, and would you know immediately or, soon if it were going to work or if the Botox was or was not working? It doesn't take a lot of time or weeks to find out if it's going to help, or does it?
It usually takes, 4 to 6 weeks to see where you're going to have that effect after. Because because initially you may have problems where it relaxes the bladder too much and you can't urinate.
Yep.
And then, the bladder's irritated from any procedure, so it takes a little while for that to kind of settle down to see where your effects are going to be.
Sure. Okay, well, thank you very much for your opinion. I certainly appreciate it.
All right, thanks for calling.
You're welcome.
Bye-bye.
Bye.
281-1150. Good morning. You're on the Good Neighbor Show with Dr. Vlach.
Hello.
Hi, good morning.
Good morning. I wonder if the doctor could suggest the best ways to help pass kidney stones, the things you could do to really help pass a kidney stone.
Well, if you're actually having the event where you're having all the pain, certainly increasing your hydration as long as you're not nauseated and throwing up, and so that you can keep fluids down. That's the single biggest thing that you can do on your own. Other than that, there are medicines that we use to try to relax the muscles in the bladder wall, which is usually the narrowest point for the stone to pass into the bladder, and then once it's in the bladder, it can be urinated out easily. So there are medicines.
Would that be the Flomax?
Yes. Yeah.
Okay, I'm on that.
Okay. Yeah, and so those are really the two things you can do to try to help it pass. Of course, with kidney stones, it depends on how big they are. If a stone is 5 millimeters or larger, statistically the chances that it'll pass on its own go down fairly significantly.
Okay, mine is larger than 5, and it is in a tube right now. And since I've been on the Flomax, I really haven't had any pain, but I don't know whether I have passed it or not yet.
Right. Well, we always want to prove one way or the other, if you're not having pain, whether you've passed it or not, because the worst thing that could happen would be that it's there, you're not having pain because it's not causing a lot of pressure on the kidney tube upstream from the stone, and then the kidney over the long term stops functioning. So we always want to prove whether it's passed or not, either with an X-ray if it can be seen on a plain X-ray, or CAT scans also are very helpful to detect that, whether it's passed.
Alrighty, thank you.
Sure,
thanks for calling. 281-1150, good morning. You're on the Good Neighbor Show.
Good morning.
Good morning.
If a man has cancer, and this has been going on, well, it was like 20 years ago, if there's incontinence, is there a surgery where they can... it's like, I'm not familiar with the correct terms, but it's like a button. My nephew said that all his problems were solved after they did this surgery that includes something that he just controls his urination by hitting a button or something. What am I talking about?
Well, I think you're talking about an artificial urinary sphincter. So presumably this man has had prostate surgery or radiation.
Right.
And he lost the ability to, the muscles were not strong enough or were affected to hold the urine in. So that's called urinary incontinence.
Correct.
And there are a couple of treatments for that. Certainly the behavioral treatments like Kegel exercises, which women do often after having babies and with the leakage problems, but we do the same thing in men. But if that doesn't work, there are 3 major treatments that have been tried in the past. First would be injecting medications or substances into the lining of the urethra to try to bulk it up and close it off. Those have really not been very helpful. So then the gold standard for this would be an artificial urinary sphincter, which is what you're describing. And
correct.
Basically, this is an inflatable cuff that's filled with saline. It's placed surgically around the urethra underneath the scrotum, and there's a pump in the scrotum next to the testicle, and then there's a little reservoir for the fluid up underneath the abdominal wall. And when you pump the pump, it takes the fluid out of the cuff around the urethra so that the urine can pass through, and then it automatically refills after they're done urinating to help hold that urine in. And so that's the gold standard for that problem. For lesser degrees of incontinence after prostate surgery, we often use what's called male slings. And that's an artificial material or strip of material that's placed around the urethra to kind of compress it. And that is quite helpful for the more minor degrees. Both of those types of procedures are outpatient surgical procedures and quite effective.
Okay, does that answer your question?
How highly do you recommend it for someone who is older?
Well, I don't know that age necessarily excludes one from having it. Obviously we want to look at their overall health and their, medical conditions to decide whether they it would be safe to have an anesthetic. But otherwise, it's really a quality of life issue for the patient.
And how long has that been around?
Artificial urinary sphincters have been around 30 plus years since the original ones. Now they are mechanically they've been refined, so they're quite reliable, and they're actually impregnated with an antibiotic so that there's a lesser risk of infection during the implantation.
So the man has complete control over his urinating then.
That's the goal, and most of the time that goal is achieved.
Okay. Thank you.
Thank you for calling. And Dr. Vlach, thank you for being here. We are running out of time. If people have questions, they can call your office, 739-3537.
Thank you for having me today.
Yes, thank you. And we hope you come back.
I will.
All right.